start with this pediatric lecture today. The topic that I was asked to talk was the pediatric abdominal mass, and basically is hard to resume a good sense of all what we get engaged with the abdominal mass in a few 30 minutes or 45 minutes, but I think I'm gonna emphasize how to approach that and what to expect when we face a child with the abdominal mass. So we're gonna start. So obviously the age presentation will depend. The type of pathology will depend as well for the age of the patient. Neonates oftentimes has prenatal workup, and we can have a sort of idea what we'd be expecting when the baby is newborn or delivered. Also on the toddlers or child age, the pathology can be quite extensive. Obviously, the most common ones, everybody get engaged in those with Wilms or neuroblastoma, but there is all sort of different pathologies that we get engaged and require surgery. And the same applies for adolescents. So, so let's start somehow with the anatomic location. Obviously, oftentimes by the time that we see the intra-abdominal mass, it's hard to define which quadrant is located because the size is so generous that most likely it's gonna be involving all four quadrants. It's very, most of the time, slow growing. So by the time that we know, it's just late in terms of the size. So we'll never find it in a small site that we can look it up in the quadrant that is affecting. So the way that we can describe this presentation is in a few words where organ or system is affecting the large mass and how we're going to approach that. And certainly we have the gastrointestinal, endocrine, urinary, gynecology, or vascular, and all these are very unique, and the pathology is so extensive that we have to be prepared for moving from one scenario to another scenario. The picture that you can see, I can tell you that is from a ovarian teratoma open procedure with a huge, and those things we occasionally see those here in our children's hospital. So what are the symptoms? Symptoms can be anything from weight loss. Obviously, long-term tumors get mass affecting to the abdomen that the kid's going to stop eating and they're going to lose weight. Loss of appetite, constipation, abdominal pain, all these are so vague in terms of the symptoms that none of them really going to bring you the idea of having a mass unless we palpate it. Hematuria, unless it's related to infection, but it can tell us a little bit about potential for a kidney tumor. Obviously, when this is related with the mass, we barely see any kidney tumor just by CAT scan only without a mass effect. And the reason for that is just because they are so slow growing and so silent, and we don't scan everybody. So can be just a finding for other reasons that we see a tumor on the small tumor on the kidney. Back pain, hypertension, fever, and onset and duration of the symptoms. So all these are very specific, but all these tumors, one way or another, have all these symptoms one way or another. Not all together, but certainly some of them. Fever could be related with the Hodgkin's, not Hodgkin's, or other malignant blood tumors. The onset duration usually takes long time. The longer it takes could be related to a benign, but not necessarily so. But all these symptoms are just very vague. The picture that we have here, obviously, is a patient that can be palpable in some degree, but it's mostly liquid. So it's lymphangioma of the retroperitoneum. So those can even be very hard to really see it on a physical exam. So when you do a CAT scan and say, all right, well, this just looks like mostly homogeneous and cystic. And part of the differential would be, obviously you have to see other cuts, but part of the differential would be a lymphangioma of the retroperitoneum. So like any other physical exam, as a physician, we have to rely on physical examination. And all this, obviously now we have so accessible the CAT scan, but all this part of the physical examinations are critical. And we have to go through all this because it can give you a sense of what's going on. Let's say inspection. I mean, I remember a baby from NICU. We did not have any prenatal care. And the mom said that the mass was decreasing in size. And I said, how come? When that happened, I said, well, I'm not sure, but every time that I change diapers in NICU, I feel that the mass is smaller. So truly, what the kid had was a giant pelvic kidney cyst related with hydronephrosis and pelvic ectasis. So it's really quite interesting to see that just having a Foley and drain it, it will become the cystic structure much smaller. So the management would be different. Obviously, we'll not jump into surgery and try to excise a big mass because we feel it. So it's important part of the physical exam to know what's going on the baby. It's just not only one time. We need to know what happened before and what happened now and how the things change. Looking for other exam on the skin, some skin discoloration, some hemangioma, some bluish color discoloration that might make you think of neuroblastoma. All these kind of make you feel that physical exam is a critical part of the examination. So let's go to some differentials here, because at the end of the day, if we're dealing with a big mass and we have all these symptoms somehow related to that, so how are we going to go from there? Oftentimes, I would say the CAT scan would be the safest study. However, if we feel that could be the kidney, well, the ultrasound, I talked later, different modalities, we'll talk about those, but ultrasound, it gives us such a good information just to start, no radiation, no IV contrast, bedside, and does not require anything, just probe. And so, but I'll go back to this later. So adrenal glands, well, the most common one that we see is the adrenal hemorrhage. It would be just either trauma or neonates, and they can be significantly large, but we don't do anything for those. The next ones that we see it more frequently would be the neuroblastoma, and those, everybody rotating through us has been exposed to that. We have recently a neuroblastoma like this one that, in case this is probably the superior SMA with extensive retroperitoneal, that is hard to define other structures. Everything is kind of push away, even the left kidney. So those look like neuroblastoma, and definitely we'll have to do some workup for diagnosis. If we move to another organ, just to kind of classify this presentation in a little more convenience, just to have it more structure, we have the gallbladder or bile duct. So what do we see more frequently here, even though that is probably the most uncommon ones out of the whole presentation, that would be the colorectal cyst. And these ones have different anomalies, depends on where the cyst is located. Either a fusiform and colorectal cell just on the duodenum, just an extraluminal cyst, or corollis when involved both structures inside or outside intrahepatic, extrahepatic colon bile duct. We have seen in our community really small ones with such a large one like this that requires obviously surgery, very uncommon. And basically you have on a neonate large right side abdominal wall mass with the elevated bilirubin and fever, you got to think about colorectal cyst. So we see tumors on the pancreas, but I would say the largest ones that we can be exposed in our practice would be the ones related to trauma. Those that we call a pseudocyst. And we call it pseudocyst because they don't have a true wall. A true wall that is formed by being attached to the stomach and other structures. The leak from the pancreatic duct leaks out into the third spacing and creates that irritation all around, creating that pseudocyst. So those are the largest ones that we can see. But however, we have seen all of these tumors here, but very infrequently. My last one from the tail of the pancreas was the insulinoma. Gastrinomas, I don't think that I have seen one, but other ones we have seen it here. However, the largest one are the pseudocysts related to trauma, and the congenital cysts are really small and oftentimes does not require any management. So we have to be very clear what the management of those. Once you identify, just call the surgeon and we'll find out. Next one would be stomach. So in this particular view, obviously I will get everybody engaged, but in this one, since we are on online presentation, it's hard to kind of get more interactive, but this is a clear presentation of Bezoar. We have recently a girl, 14-year-old with a large Bezoar into the stomach. Obviously that girl has an epigastric mass, had lots of appetites, had early society, losing weight. So at the end of the day, when you have a upper GI, well, I have an endoscopy, but in this particular picture, it had a CAT scan that shows the huge filling defect on the stomach consistent with the Bezoar. Other anomalies, we see them, but infrequently, like a duplication and other ones. When we go to the intestinal tract, those tends to be quite uncommon as well, because those are usually small, even though that can be rather large. Leiosarcoma is very rare. But in this particular one, it's intestinal duplication. So a portion of the intestine, usually in the right side, usually in the ileocecal region, had a duplication of the terminal ileum. And those usually give symptoms without becoming that large. But certainly in that picture, it's big enough that might be palpable. However, the most frequent mass effect on the daily rounds and the pediatric floor is, here you go, fecal impaction. Everybody gets those cases daily, and those requires, you all know, cleaning from above, cleaning from below. Other lesions usually tend not to be that large to be palpable. When we go into the lower unitary urinary tract, then what we see more frequently would be ovarian cysts, but unless it's more than 4 or 5 centimeters, usually we don't do anything because we feel they are reactive. And those are not palpable. But the ones that are palpable, like one that we show in one of the previous slides, are dermoid, germ cell tumor or dermoid tumor. And those can be from top to the bottom, are so slow growing that it can feel, you grow with it, so you don't feel it that early in the stage. So basically, unless there is a torsion, but when it's so big, it doesn't twist it. In this particular case, can get twisted, and you have symptoms for torsion and vascular compromise. But certainly those, when you test them, either with the X-ray, ultrasound, or CT with particular this one, you can see some calcifications, and usually are rounded and usually are located down into the pelvis. The other one that we can see on the neonatal time is PUV, posterior urethral valve. Those are only boys, and those usually have a massive bladder from obstructed urethra, and those requires a laser treatment to burn those posterior urethral valve to allow to decompress the bladder. Sometimes they need, if the bladder is so big, sometimes they need some decompression as well, or vesicostomy. But most of the time, those are seen during or expected during a prenatal care for oligohydramnios. All right. So kidneys probably are the ones most commonly seen one way or another. It could be just a solid, like a Wilms tumor. It could be just hydronephrosis, so just liquid. I have seen all of those. Multicystic kidneys can be so big that it can compromise the abdominal cavity. Have a newborn 1.2 kilos, they have a dysplastic kidney. And both kidneys were so large that we had to take it both one after the other just to allow the abdomen to have room for breathing and for intestines and other organs. Anyway, it's just, but there is a lot of pathology related with the kidneys, vesicourethral reflux, hydronephrosis, UPJ obstruction, upper pelvic junction obstruction. So those are significantly frequent and seen in the practice. So we have to work them out first with the ultrasound. Those tend to be quite uncommon. Tumors related with the liver, newborns less than 2 or 3 years, hepatoblastoma, very aggressive, very large. Oftentimes, by the time that we see them, you might require transplant. Focal nodular hyperplasia, this is mostly related in adult teenagers that may be with hormone treatment. Storage disease, you will see it more from the pediatric side, but basically are altogether very uncommon. Recently, we have a large liver abscess that was on a teenager that has to be drained and treated such to allow it to decompress and recover. And spleen, obviously those who are engaged with the sickle cell, we see, or hem-onc, we see massive enlargement of the spleen, typically related to spherocytosis. And those are surgical needed in those require more severe cases, but other entities, malignancies or infectious are involving the spleen, and then it basically might cause the large mass. And this one that we had here a while back, it was a large lymphangioma, retroperitoneal, but encasing the whole abdomen. So you can have a mesenteric cyst or mental cyst, that's less frequent, but certainly you can have all sorts of different tumors that are palpable for examination. So those are massive growth that are very slow, and by the time that you find out, you basically have such a big defect. So how are we going to get to that point? So how we find out? Well, we have all sort of different imaging studies that we can do, and certainly an X-ray can give us a lot of information. Let's say the proximal, this one X-ray, you can see palpable mass probably on exam, and then when you see the bowel just shift to the other side and radiopaque, not really big, but haziness on the left side. So, well, obviously it's something there. But at the same time, you don't have anything such of a stool or constipation. So you got to think that probably ultrasound would be the next step here. It's all distorted. Or you can have this neonatal case, a newborn with a calcified image here that most likely could be just a dermoid from the pelvis, but it's so big that it's just outside of the pelvis. It just does not fit down on the pelvis. And remember, the ovaries are more in the groin area than in the pelvis unless you grow to older age. So plain abdominal x-ray still have very valuable information that for screening. Ultrasound, good things about the ultrasound, it gives you a lot of information. It's a bedside, no sedation, no radiation. It can give you certainly very valuable information for those patients that you want to work up for a kidney or uterine anomaly. Obviously, for a surgeon, when we get to this point, CT scan probably the most valuable information for us, even though you need contrast, you need to set it up, you might need to give some sedation just to avoid some bad studies for artifacts moving the patient, the fact that it's radiation, we're trying to kind of radiate less and less these days, and IV contrast. All these putting together, it's a little more laborious, but it's a wonderful test for figuring out the lesion. This MRI is just for specific locations, such as tumors, neuroblastoma involving the spine. That will be the most valuable one. However, other areas might not be that important. We have recently Wilms tumor with the horseshoe anomaly. So it's valued to have a CT with arteriogram, a CT with angiogram, or ultrasound with a vascular Doppler just to assess the blood vessels. Is the tumor involving the main renal vein? In that particular case, has a horseshoe that we were able to see on the CAT scan, but also after the first initial chemotherapy ready for surgery has a tumor that has moved towards the retrohepatic IVC. So those, sometimes you need some well-done CT scan with angiogram to be able to define. Certainly you need to be prepared. In this case, it requires a more leverage surgery and more high-risk surgery. And certainly the nuclear scan for those cases that it might be very specific and not for the most variety of tumors. What we're gonna do with the labs, always all of them require basic labs, CBC, all this will give you some information prior to manage those kids. Certainly for surgery, you have to have one. CMP that will give you some hint about the uric acid or LDH levels, also for some electrolyte abnormalities like we had with the insulinoma or other pathologies that are worth to have it work up as a blood test. Urinalysis, hematuria, proteinuria, just renal involvement, and that's another test that you might be more specific once you have a better idea what you're dealing with. The test for HVA or VMA, all these are very obviously specific for tumors that secretes neuroendocrine hormones, neuroblastoma or FIO. Other ones, markers that we use for ovarian tumors for a dermoid or others. Usually we get quantitative HCG or alpha fetoprotein. Also, sometimes is required for having a better workup, the involvement with the bone marrow biopsy and aspiration. Let's move on to, so after all this and having a big time headache with all this information, obviously we gotta go to what is most common out of this. Obviously, looking around and see what would be the most common. Obviously, would be age related, but if we would look it up all together, renal related abdominal mass, probably about over 50% most frequently organ involved. And I would say that Wilms and hydronephrosis would be the two most common that we're going to see involved in the kidney. When it's not renal, but it's still located on the retroperitoneum, I'm not sure how that red line came up, but hopefully it's not me. It's just, well, anyway, so non-renal retroperitoneal neuroblastoma is certainly the one who we see more commonly. And remember, Wilms tumor, we might have 500 a year in the whole United States, just to give you a little sense of how many are seen in the nation. And neuroblastoma, maybe around 900 cases throughout the United States. Then more uncommon, we have just related to gastrointestinal side or hepatobiliary tumors that are just more unfrequently. So I hope that that gives you a little overview of what to do when you get exposed to the abdominal mass. If you have any questions, just get on mute. I'm happy to address that. Thank you. I know also that it's lunchtime or maybe post lunchtime, so I didn't want to take it too much time for you guys to be able to have that done. So if I don't hear from anyone, you can type or you can do it verbally. Remember, you have to unmute your computer. But if I don't hear anything else, I'll finish with the presentation. All right. Well, I don't hear anything else. Thank you and have a good afternoon, everyone. Bye.